Hello and welcome to Live 2021, a series of 18 webinars on various aspects of kidney disease and kidney replacement therapy. This is webinar number 10, and it's my first webinar I co-chair in the new year. My colleague, Professor Peter Stenwinkel, has already chaired the first one in 2021, and this was January 14, I think. So today we have number 10, and the topic of today is home hemodialysis and cardiovascular disease. We have two top experts today, which give us two presentations. And Dr. Maria Slon Roblero from the Department of Nephrology, Complejo Hospitalario de Navarra from Spain, will give us an introduction on home hemodialysis. And our second expert today is Dr. Maxence Ficheux from the Department of Nephrology at the University Hospital in Caen, France. So they will talk about home hemodialysis and the focus on the cardiovascular protection. You who are listening, you are invisible and you are on mute, but you have a chat function button on the right bottom, and you can think about questions and already enter them into the system, and I will bring these questions at the end to the speakers and we will respond to them. And I have another message of today. I heard that this series of webinars are visited by many listeners. And there are hundreds of you today listening, including those who are watching the webinars which are deposited in a repository. And you can see them and listen to them later tonight or in the next upcoming days. So this makes us professors who have advised the program and the content of the program, of course, very happy, because we feel that this program is of interest to many of you outside there across the world. So now I'm handing over to Dr. Maria Slon Roblero about the first introduction. And Maria, the floor is yours, please.
Thank you very much. Good afternoon, everyone. It is a pleasure for me being with you today through this live 2021 session. Today, Dr. Ficheux and I will talk about home hemodialysis focused on cardiovascular protection. I will give you the introduction, and then Dr. Ficheux will show you some clinical evidence. So in order to understand the relevance of this topic, let me start looking ahead briefly to the current situation of our dialysis population. As we know, the number of patients undergoing renal replacement therapies continues to rise worldwide, and it is expected to increase even more in the following years, as you can see. Taking into account data from the European registry, we can find out that even though survival of patients who start renal replacement therapies has improved in recent years, the life expectancy of dialysis patients is still much lower comparing age-matched population, including general population and transplant patients, as you can see here. With cardiovascular disease as the main cause of death in these patients, taking into account data from the last US annual report, a fact that remains unchanged over the years, as we well know. I would like to emphasize that, of course, kidney transplantation would be the best treatment option for our patients in all aspects, including cardiovascular protection. However, if we take a look at what is happening in Europe, taking as an example the European registry again, we can realize that a high percentage of incident dialysis patients will receive a kidney transplant during the first years of treatment, as we would desire for everyone. However, An important number of these other patients will remain on dialysis for several years or will not be able to be transplanted at all. So what are we going to do with all these patients that will remain on dialysis? I would like to draw your attention to the fact that conventional in-center hemodialysis continue being the most widely used dialysis technique worldwide, as you can see here once again from the last US report, with a conventional prescription in the majority of these patients. In spite of the fact that there are still important unmet clinical needs that conventional hemodialysis has not been able to solve in terms of high-risk cardiovascular morbidity and mortality related to all these factors, as well as diminished quality of life. At this point, I think it's necessary to comment that this situation perhaps is not the result of demonstrated clinical superiority of the prescription, but it is the result of increasing financial and logistical pressures. I am sure we all agree that we have enough evidence so far to realize that conventional hemodialysis is the minimum treatment necessary to maintain life, but it is inadequate in preventing dialysis-related complications and improving patients' outcomes. And probably the main reason why the outcomes with this prescription are limited or not acceptable in terms of morbidity and mortality is due to the intermittent nature of the prescription, with limited ability to remove uremic toxins, limited volume control, and because of the persistence of the long interdialytic interval that is strongly associated with increased risk of death, hospitalizations, and cardiovascular events. So we need to stop here and think, what else should we do to improve our patients' cardiovascular outcomes? Let's see if I can give you some ideas about this during next minutes. Just a simple refresher, I would like to remind you that the high incidence of cardiovascular morbidity and mortality in dialysis patients is multifactorial. These patients have increased not only the traditional and non-traditional risk factors, but also they have risk factors specifically related to uremia. Therefore, dialysis modality, according to its ability of uremic toxins clearance and volume control, may directly impact on the cardiovascular risk and outcomes of these patients. So, taking into account what I have said before, if we increase the dialysis ability to remove more uremic toxins and improve volume control, we can directly impact in some aspects and improve or at least decrease some of these risk factors related to cardiovascular outcomes. But how can we achieve a graded uremic toxin removal and a graded volume control? Well, the easiest way to do this with something we have already available in our hands is through more frequent or longer hemodialysis sessions, more weekly treatment time. By prescribing this way, as you can see, we can achieve many and different benefits for our patients related to their survival and also quality of life, just by achieving more uremic toxins removal and more volume control at the same time. I want to show you this picture again because I found it very useful to strengthen the idea that prescribing more frequent or longer hemodialysis sessions is the dialysis option that more closely mimics the kidney's function, as you can see here from this KDIGO controversies report. However, it is true that in addition to benefits, intensive hemodialysis do also have risk. And although this prescription has great potential benefits, not all patients may experience them. So we need to be aware that dialysis prescription requires individualization with a patient-centered approach. So going back to our topic, even though both aspects are very important, when dealing with cardiovascular protection, a graded volume control is key. So during next minutes, I will focus only on this issue. I want to emphasize that there is a tension imbalance in volume status in dialysis, as we know, with multiple interlinked volume-related factors within a narrow therapeutic window in order to avoid complications related either on volume depletion or volume overload, both of them independent risk factors for cardiovascular morbidity and mortality. It is clear that volume overload is a major risk factor for all-cause and cardiovascular mortality in dialysis population because it is associated with hypertension and left ventricular hypertrophy, as we know. However, not only volume overload, but also high ultrafiltration rates are associated with high-risk cardiovascular morbidity and mortality as well, because it is associated with interdialytic hypotension and myocardial stenting. Just a simple refresher, we cannot forget that there is a strong association between rapid ultrafiltration rates and increase in mortality. This risk begins to increase at ultrafiltration rates over 10 milliliters per hour per kilogram, and higher ultrafiltration rates are significantly associated with even more risk, as you can see. I want to draw your attention because even a moderated ultrafiltration rate, less than 10 milliliters per hour per kilogram, as you can see, has been associated with increased risk of death, as you can see here from this plot. But how can we mitigate the ultrafiltration rate? Well, this challenge centers either on reducing interdialytic weight gains by increasing dialysis frequency as one possible option, or extending dialysis treatment time. So once again, the same argument since the beginning, as you can see here, increasing volume control by more frequent or longer hemodialysis sessions. So after everything I have mentioned before, we can realize that extending treatment time or frequency is an effective way to address volume control and tolerance of dialysis sessions with less related morbidity and mortality, because we can act directly on the cause of these on the cause of these factors related to cardiovascular outcomes. But going back to our topic, what does home hemodialysis have to do with all this about more intensive dialysis treatment and cardioprotection as well? Well, there is a simple answer for this question. I have to say that home hemodialysis is not cardioprotective per se. What home hemodialysis truly provides is an excellent environment to perform more intensive hemodialysis regimens by allowing greater flexibility of schedules with a patient-centered approach without affecting the organization or structure of a dialysis unit in an economically and sustainable way. There is increasing evidence of the significant advantages of home-based dialysis therapies, which are cost-effective and patient-centered compared to in-center hemodialysis. These benefits are related not only in improved cardiovascular clinical outcomes and possible improvement in patient survival as I mentioned before, but also because of an improvement of patient rehabilitation, a dramatically better health-related quality of life, and reduction of the economic burden, streamline healthcare costs. Just before I finish, I want to show you this chart from the KDIGO Controversies report, where different approaches to achieve a better volume control in our dialysis patients are shown. As you can see here, one of the first approaches in this report is to individualize the prescription, increasing dialysis duration and frequency according to patient needs. And here is where home hemodialysis takes on relevance as a key for individualizing dialysis prescription, as I mentioned before, helping us to achieve improvement in our patients' outcomes and reducing cardiovascular complications. So I hope that after everything I have said, I might give you some ideas to understand that regarding cardiovascular protection, and because many other benefits for our patients, we really need to think whether instead of prescribing conventional in-center hemodialysis to the majority of our patients, we can turn to alternative dialysis prescriptions to improve our patients' outcomes. And here is where home hemodialysis takes on relevance as a potential dialytic strategy to achieve maximized quality of life and possible improvement in patient survival. Just to finish this presentation, I hope you can agree with me that home hemodialysis is key when trying to do something else in order to improve our patient cardiovascular outcomes. Improving this situation is possible and is not a dream. Thank you very much.
Thank you, Dr. Slon Roblero. Very structured indeed, and your conceptual framework looks perfect. Maybe not a dream, but maybe we hear this now from the second speaker. So first of all, I want to thank you, and we will have you later on with the discussion with us. So now we walk over to Dr. Maxence Ficheux. He is the second speaker, and he will bring this conceptual framework a little bit more into the clinical context, and you will tell us how you are doing this and what you think about. So please, Maxence, the floor is yours.
Thanks a lot. Good afternoon for everybody. So I'm Maxence Ficheux from France. I work in Caen in Normandy, in the west of France. I'm in charge in my region of the Home HD program. I will speak today about the interest of Home HD for cardiovascular protection. After the nice talk of Maria, we try to focus on clinical evidence. There's a problem. Sorry. Okay. So perform dialysis at home is not only a change of treatment location. It is often a change of dialysis schedule. There is in fact mostly two different options at home. The first option is daily short dialysis session with specific machine like Nextase. The second option is nocturnal dialysis session, often with conventional machine, even if long night dialysis can be performed with next-stage machine. On this figure from New Zealand and Australia, at home we can see more frequent dialysis. Indeed, almost half of home patients perform dialysis more than 3 times a week, and more hours of dialysis per session. Almost all patients dialysing for 6 hours per session or more are within in the home population. So patients at home perform intensive dialysis, more frequent and more hours. But the question is, do we have evidence for better cardiovascular protection with intensive dialysis? I will try to show you very briefly evidence of this issue. In the next 3 slides, I will show you data from FHN daily, nocturnal, and Canadian trial. The FHN daily trial compared frequent dialysis with conventional dialysis. The nocturnal trial compared nocturnal with conventional dialysis. And Canadian nocturnal trial compared nocturnal with conventional dialysis. These different studies have demonstrated that intensive HD comparing with conventional dialysis significantly lower blood pressure with reduction in antihypertensive drugs compared to conventional dialysis. More frequent or longer dialysis sessions have demonstrated regression of left ventricular hypertrophy compared to conventional dialysis. With a lower incidence of intradialytic hypotension with intensive HD compared to conventional HD, especially with longer sessions such as nocturnal prescription, as you can see here. Because we treat directly the main cause of hypertension, reducing weight gains between sessions by increasing dialysis frequency or extending dialysis treatment time. So we have evidence for nocturnal dialysis. We have evidence for frequent dialysis due to FHN trial, but in the FHN trial, frequent dialysis was performed in dialysis center with conventional machine and not at home. In the second part of my talk, I will focus on home daily dialysis with low dialysate flow. In fact, I will focus on next stage treatment. The question is, do we have any evidence for daily home HD with low dialysate flow? This type of treatment is more new. For example, in Europe, we have used the next stage machine for less than 10 years. Despite the young age of this treatment, we are starting to have interesting evidence. In this cohort study from United States with the Universitario registry data, we are comparing in-center dialysis patients 3 times a week with daily HD patients with the next stage therapy. We can see that the mortality goes down significantly with 13%. It was the first good sign of a very good efficiency of the home daily treatment. The previous slide is really interesting, but it is American data. We know that in the United States, the organization of healthcare is different, and so are the patients in comparison to Europe. Therefore, it is interesting to have European data. I had the chance to be part of a group of European nephrologists using next stage in Europe. We have decided a couple of years ago to create an European cohort named Kidney Cohort. Kidney means knowledge to improve home hemodialysis network in Europe. In this cohort, all patients on home daily dialysis with the next stage system for more than 6 months were included. We have 219 patients from 12 centers across 5 countries. I will show you the result. The mean age of the patient in this cohort was 49 years, but we can see a wide variation as the youngest is 15 up to as old as 84 years. The average body mass index was 26 with a range between 13 and 15. To the right, the other important thing on this slide is the percentage of patients with comorbid condition. You can see most of patients have a comorbidity score lower than 3, but you can see some patients have a really high Chalson score, and despite of that, they are still suitable for home therapy. look at the antihypertensive usage. What we found is that the number of patients who need no antihypertensive drug increased from 27% to 42% from baseline to 1 year's follow-up. On the percent of patients who need 2 or more antihypertensive drugs, significantly decreased from baseline to 1 year follow-up from 40% to 25%. We were able to reduce the antihypertensive usage in our patients in a significant manner. On average, the cumulative treatment duration is 40.9 hours per week. This is a long duration when we compare to the 12 hours per week with conventional dialysis in the same European countries. In this group, in average, the patient had an ultrafiltration rate of 6.4 milliliters per hour per kilogram. The majority of them had ultrafiltration rate less than 10 milliliters per hour per kilogram. This is a very important point, as Maria told previously. In fact, our patients perform more frequent dialysis. The ultrafiltration rate is significantly lower than when you do 3 times a week. Fluid overload is an important issue in dialysis patients. Fluid overload is clearly associated with hypertension in dialysis population. We can now measure fluid overload with bioimpedance with the BCM, body composition monitor. But do we have any data about fluid overload for patients treated at home with daily dialysis? The question, in fact, is what is the more important? Is it normal hydration or is it normal blood pressure or both? Professor Zuccali had addressed this question in this cohort study with more than 22,000 incident dialysis patients that was studied for 1 year. You can see in patients with normal blood pressure, that was the reference, in this normal hydrated patient, an increase of blood pressure or lower blood pressure was associated with an increase of risk by less than 20% of all mortality causes. But in the fluid overload patient population, even with a normal blood pressure between 130 and 160 milliliters of mercury, before dialysis session, there was a significant increase of 51% of increased risk of dying. Hypertension was associated with 62% increased risk of dying, and patients with low blood pressure, because of heart failure, have a much bigger risk of dying in the dialysis population. According to this data, fluid overload appears to have the higher risk of dying more than blood pressure. In a PD population, we can observe almost the same result. PD patients with fluid overload have a worse survival curve than patients without fluid overload. The question is fluid overload frequent in the dialysis population? We have this information in an in-center dialysis population. More than half of the population develop fluid excess. It is the same in a peritoneal dialysis, 53% with fluid overload and 25% with severe overload. On the other hand, we don't have data from home dialysis patients. We have conducted in my hospital a study to answer this question. We have enrolled 39 patients in this study from 10 French hospitals. The patients are daily home dialysis with next stage system. Before a dialysis session, a BCM, body composition monitor, was done to assess excess fluid. You can see on the figure that the result of the impedance metric. 50% of the population have a normal fluid composition. 26% have a small fluid overload, and only 13% have a severe fluid overload. So in total, 39% present a fluid overload status. Fluid overload seems to be less frequent in daily home dialysis when we compare with the PD or in-center dialysis population. Our study has a lot of limitation because it is a small cohort. We can see on this slide that our home HD population is younger than other population, and we can observe a small proportion of diabetes. Nevertheless, this result is rather promising, and in my point of view, this good fluid control must contribute to improve the quality of life of home HD patients. To conclude, if you want to offer intensive dialysis, I'm sure that home is the best location. Home allows you to increase the dialysis frequency or extend the hours of treatment. With flexible prescription, you will decrease the ultrafiltration rate and the number of antihypertensive drugs. And you will increase the fluid control, and this is a parameter to consider because fluid overload is associated with mortality. Fluid overload is more dangerous for the patient than hypertension in a dialysis population. Thank you very much for your attention.
Thank you, Dr. Ficheux, for this clinical data and nice overview. I think we have some time to discuss, and we received many questions from the audience, and I still want to remind the audience you can still ask, and we can do flash talks at the end if too many questions are coming. So there is still the chat function is open, and you can still enter while we are discussing, and you have maybe some ideas ready. So let's go to the first question and ask ladies first. Maria Slon Roblero, a question for you. And I read the question that you can focus. The question is, could you comment on potassium and arrhythmia connection as far as individualization of dialysate versus one-size-fits-all dialysis is concerned? So it's a long question, it's complex. Let's focus potassium, arrhythmia, and some individualization of dialysis or dialysate. Please.
It's a very good question. And I have to say that this is something that I already mentioned in some aspects in my presentation, because I think now in this time, everything is turning around a patient-centered approach. So I totally agree that one-size-fits-all approach is not a good way to do things. And the thing with potassium and arrhythmias is that the shift in potassium during the dialysis session is the most important issue for a patient for increasing the risk of arrhythmias. So a patient that comes to dialysis with high risk levels of potassium, and we dialyze them with a low potassium in the dialysate, they will have a big shift in the serum potassium. So that is the main risk factor for arrhythmias, and it happens every time. And most of the times in center, if we do not individualize the dialysis prescription, telling something related to not the frequency or the duration, but also the dialysate composition. I have to say that if we increase the frequency, the levels of potassium are almost more the same levels than if we have 3 times a week, that is big difference and big peaks in the serum potassium levels. So I have to say that not only increasing the frequency is a potential way to decrease that shift in the potassium serum, but also to individualize the dialysate composition to in a more patient-centered approach. I don't know if I answered the question, but I hope this is something I explained.
Yeah, or let's extend this question to Maxence. Maybe he has also experience, and ask him, are there data out there which are saying that the home hemo patient has a more constant dialysate potassium bath than the in-center? Maybe we do too much in-center in shifting around the potassium, and home hemo is more stable. Are there data, or can you say something to this?
The question is, what is the potassium in home daily dialysis? Is that?
Yeah, home hemo patients may use more stable, constant potassium dialysate than in-center. Could this be?
Yeah, I understand, but in fact, I don't know if we know that. We know that when what we know is the potassium for patient at home is really good and is not high because of frequency. And in fact, when you need to make a prescription for daily dialysis, because with next stage, for example, because you have a low dialysate flow, you need to decrease the concentration of potassium of your dialysate to have the same result of in-center dialysis. So, for example, if you use a dialysate concentration of 3 at in-center, you need to use a dialysate concentration of 2 millimole per liter in dialysate to have the same result.
Okay, good. Let's have the next question. This is on potassium and arrhythmia. And the next question goes to you, Maxence, again. And I read the question. It's rapid electrolyte shift during dialysis affect the myocardium. How important are these DP chemical gradients?
Can you repeat the question?
Actually,
please?
it's a rapid electrolyte shift. Yeah. And we know that we have myocardial stunning when we have intense ultrafiltration rate. Yeah? And here the question is also whether a rapid electrolyte shift during dialysis may also affect the myocardium.
In fact, I don't know. I don't know. Maybe Maria, you know?
Yes, I think it's something is practical, the same answer for the previous question. I think myocardial stunning is not just for rapid ultrafiltration rates. It is very demonstrated in this aspect, but also in rapid shift related mainly to potassium, to calcium, and in magnesium too. So the problem with intermittent dialysis is the big shift, not only in the dialysis session, but you need to remember the long interdialytic interval. So this shift is even greater in the long period that people are not getting dialyzed. So this is one of the main problems, not only related to volume, but also related to electrolyte rapid shift. So I hope we answer this question.
Yeah, good. Dr. Ficheux, I remember that we stopped using a potassium dialysate of 1 millimole because of the effect on the myocardium through arrhythmia. Isn't this true?
No, it's not true. You need to decrease, not for this. You need to decrease because you have a low dialysate flow. So you have the diffusion is lower because the flow is lower. So you have to decrease to have the same result. It's not high efficient dialysis. So you need to decrease the the concentration of potassium to have the same result. Is it clear now?
Okay, good. Yeah, let's do another question, and the next one is to Maria again. How do you explain that nocturnal hemodialysis in the FHN trial shows less survival rate? And here the question in brackets is residual renal function,
Yes.
or
Yes.
what is the explanation?
Yes. I have to say that I know one of the nephrologists that participate in this trial, and something that he told us some years ago. So there were a lot of bias in these studies, even though they are the greatest quality because they are randomized controlled trials. There were like some bias in the selection in the patients and in randomizing the prescriptions. I have to say that it is true they didn't get a better survival comparing conventional to frequent, but this is something we need to prove in other. Probably we need more studies to prove this situation. And I have to say that even though they do not find the benefit of survival, they found a lot of indirect or other parameters related to cardiovascular survival, as less ventricular hypertrophy or regression in the ventricular hypertrophy of the patients. They shown the better blood pressure control. So they found some of the aspects that really impact on cardiovascular outcomes for our patients. So probably in that trial, they didn't, or they could not prove that the better survival, but they also demonstrated a lot of indirect clinical benefits that potential, or they have the potential of improving patient survival. Something related to residual renal function is that these studies were not designed for demonstrated the benefit of the renal function, and they were not measuring the renal residual function in all the patients that participate in that study. So this aspect related to renal residual function is something that this study was not planned to demonstrate results in this aspect in particular. So this is another bias in to interpret that there were less or there were worse results with this. Probably we need, as I said before, we need better studies or different studies specifically related to understand or to demonstrate the association between increasing frequency or duration. So probably these studies were not planned to demonstrate it. This is particular issue.
Great, good, okay. We have more questions and we have to go through them. I take the next one, which is again to you, Maria. What is, in your opinion, the most relevant factor? Is it frequency or time? Duration yes. of the session.
I have to say
in the equation you have
I have to say
you have ultrafiltration, frequency, and duration. So
yes.
In essence, is it time?
No, I have to say that, as at the beginning of my presentation, we need a patient-centered approach. Home hemodialysis is for flexible schedules and flexible prescriptions. So it depends on the patient. What is the most important or relevant factor in that specific patient. And we need to say, I have to say that this is, even though it's not just the prescription, it's the quality of life that the patient needs or the patient wants. So the nocturnal prescription, the most important thing is quality of life. Patients like to have the whole day for their own activities, their own things. So this is just much more for quality of life, even though it's very important related to phosphate removal and volume control. But the main reason why a patient choose either frequent or nocturnal is because their activities and the priorities in their life. So I have to say that is just for a patient-centered approach and to individualize dependent on patient needs.
Very interesting what you are saying, that happiness is also coming into the equation when I'm smiling. But I would like to ask Dr. Ficheux, are you also with the same opinion, or is the factor time more important for you? Or do you think Maria is completely right? What can you say else now?
Yeah, I think Maria is right, and I think it's complementary things: duration, frequent dialysis, and nocturnal dialysis. I think patient can change between his follow-up. For example, I have a lot of patients who start with frequent dialysis, daily frequent dialysis, and with the time, it's difficult because of the activity. Sometimes difficult to have daily dialysis, and they can move to have nocturnal dialysis. I think it's really a patient choice, but the both is important, in fact.
Good. So let's go to the next question. And we have now to Dr. Ficheux. What is the lowest number of home dialysis sessions patients should do to get a significant effect on their quality of life in comparison to in-center hemodialysis? Though the lowest number of home dialysis sessions.
I think the question is for with next stage treatment, next stage machine, I guess.
Or
so,
any method, yeah.
What I think, to have the really the evidence for frequent dialysis, you need to have 5 sessions per week, because if you want to be frequent, you don't have to. It is not good to have 2 days without dialysis. So you need to have 5 sessions a week to have to say it's frequent dialysis. So with next stage, with 2 hours and a half a session, you need 5 sessions per week to have the benefits.
You know, we have an audience which is coming around the globe. And maybe this question can come from a country where you think differently, count differently, and people expect from 2 sessions per week times 6 hours the same. Then you go 6 times per week, 2 hours. Yeah, I mean, maybe this was behind the lowest number. Patients always want to negotiate with you to go lower, or less hours.
May I? Sorry, may I?
Yes, please.
Add something. If the question is just how to get a significant effect in quality of life, just being at home is a significant effect, not going in center. If we talk only in quality of life, because patients have a flexible schedules, they do not have to go to in center. They don't have to move from their houses. But if you do as a conventional prescription, you lose the benefits of a frequent prescription or more intensive dialysis prescription. If we talk about quality of life, probably everyone who stayed at homes would have better quality of life. But if you do a conventional prescription, you are not going to achieve the benefits of a more intensive hemodialysis benefits that you probably could achieve if you do more intensive regimens. So quality of life is I think that the minimum benefit you have staying at home if you are a person that could do this kind of treatments, we have to say.
Okay, I think the audience has heard the message very clearly now. We go to the next question. I think we still have some time. And to Dr. Ficheux, do you have the nutritionist status with body composition monitoring in your SDHD with low dialysate flow?
I don't have the result of nutritional status. I can wait because I have the BCM result, but I don't focus on this status. So no, I don't have any data about this. But sure, what we can say it's with frequent dialysis, with home HD, with frequent dialysis, the patient the nutrition status is really good because the patient can eat what they want because of the frequency, and really there is no problem of malnutrition with a home HD patient with next stage, for example. But I don't have with the result of the BCM with this.
Yeah, and how often do you BCM in routine treatment, usually? Yeah, I know if you have a home hemodialysis patient, you can do it only when they come to the center every 6 weeks. But in center, how often do you BCM?
In center, maybe every 2 months. 2 months, I make
longitudinally.
BCM. But at home, we don't use BCM usually for patient at home. We have used for the studies that I show you, but we don't use a lot of.
Yeah, in some countries, patients come from home to the center in intervals to get blood draws and the health status quantified and measured. And I think this time could be done. Yeah. Okay,
yes,
good. This is about. Nice. Yeah. Another question before we then wrap up is who wants to take this? Is a long one I'm reading. So, how frequently were the home hemodialysis prescriptions tailored to address concern of fluid overload? Are there any studies looking at patients' mortality and individualized prescriptions?
And I have to say that we each visit to our clinic. The home hemo patients come to our medical visit every 6 weeks, as you said. We work at the same way, and every time they come here, we check if they have changed the weight gain, the weight, or they are good in blood pressure, if they have any clinical evidence of volume overload. But they learned how to move these measurements, so they are in a good volume status almost every time. But every 6 weeks we check that this is true. So I have to say that home hemodialysis patients they learn how to move the weight to be not only not with volume overload, but also not to be in a weight that could be with hypotension or bad hemodynamic tolerance. I think they are, during the training, they learn how to do this. So I think there are a lot of studies, but they are observational studies that shows the better survival in frequent home hemo, and they are probably studies from America. They are a lot. I think this is not time to mention them, but there is a very interesting web that is advancing dialysis. I recommend you to visit this website, and you can find a lot of information about this kind of studies.
Let's ask one question to you both, which is a more general one and concerns the pandemia. We talked today a lot about home hemo, and we have seen data, and this was a very good discussion and important. But we are now in pandemia since 1 year, and pandemia can change or is connected with going home. So my question to you, or going home, is maybe also more connected to peritoneal dialysis than to home hemo. And we have also seen data from PD today. So according to your experience during this year, did you see any change that you could shift patients at home because pandemia is more safe for them? For example, by using PD, if you have a PD program, or what did you see over the year, and what do you think will happen in the future?
Maxence, do you want to answer, or me? I have to say that during this pandemic situation, home hemodialysis treatment shows a new benefit. We always have this benefit related to less infections. We have less infections related to blood virus, but now we realize that people were more safety at home. And this was like a new discoverment that home treatments can make people more safer because they stay at home. They do not have to go anywhere to get dialyzed. So people wanted to stay at home. So this is like a new benefit. People are happy to stay at home and they do not need to go to the hospital. That probably there would be more risky situations. So they learn how to do this, and they appreciate it, I think, better than before. And
is there any information from France whether the program has expanded?
We have seen that there is almost 0 patient at home who have the COVID. So it's really nice for patient to be at home, because there is a lot of patient with COVID in center for patient who make the dialysis, who perform dialysis at center. So I think it's really good arguments to go at home, and I'm sure this will move something for the patient choice. But I think we don't have maybe it's too we don't have time to see that, but we will see that maybe in the next months.
I have only single center experience. There was a time about 4 months ago where we had a lot of requests, and we run out of PD catheter supply because we had these requests to go home in this type of treatment. I think we had an interesting discussion, so I thank you for this. We had also good questions from the audience, and thank you for the audience. To the audience, and thank you for joining us tonight, and congratulations again for your talks. Thank you.
Thank you.
So let's move now over to announce the next webinar, and this is number 11. And we have invited Professor Kitty Jager, a professor of medicine, epidemiology and statistics from the AMC in the Netherlands and Amsterdam Medisch Center, and Dr. Raphael Duivenwoorden. And they will come back to us on March 11 and talk about the ERA-EDTA registry, the European Renal Association, European Dialysis and Transplant Association Registry, with a focus on the ERA-CODA study, which is a study which has been supported by the ERA-ETA, but with a tremendous effort of a group of researchers in the Netherlands, and this was pushed by Ran Gonzewort. And now, next time, Professor Kitty Jager and Dr. Raphael Duivenworden will report an overview, first results, and what we can learn from different approaches on COVID-19. Therefore, I ask the final question to transition to the next webinar on March 11. So thank you for listening for tonight, and I hope you have a good rest of the day. Thank you.